Sister Kay Dyer is a cardiac liaison sister at Birmingham Children's Hospital. During this interview, the issues surrounding treatment at a children's hospital will be explored, with parental involvement in care being highlighted. The lifestyle challenges that most children face will also be discussed, including information on feeding, education, and exercise.
As a liaison sister, I get referrals from the fetal medicine department here telling me about ladies expecting babies with a univentricular heart. They often are keen to see the hospital and the environment to which they will be placed if they decide to go down the surgical pathway. And we would very much encourage that. So, and I would arrange an appointment with the family, and they can bring as many family members as they would like. And I will show them not only the baby ward where the baby would be placed once he or she is born, but also gives them an opportunity to ask any practical questions, and also I can advise them on any issues, perhaps lifestyle or choices of treatment and things like that. Often as well, the nurses and ourselves were always asked, can I look after my baby once they're in hospital? We would obviously very much encourage that, but sometimes parents are quite anxious about the tubes and machinery and everything that the baby has to be wired up to. But with help and encouragement, we would obviously encourage them to look after them, because at the end of the day, it's their baby, not ours, and they are just as important to us as their baby is. So we would support them in every way we could. I think it's very difficult for families to decide what and when to tell the family about this baby that they're expecting. I think they have to decide what's right for them, but just to bear in mind, whatever course of treatment they do decide, it's important that they probably have the support from their family members, particularly if there's other children to look after as well, because it will affect every single person in the family and the extended family, and obviously close friends as well. So I think it's important if you can get your family members to help, perhaps practically and emotionally, and sometimes financially also as well. Often as a liaison sister, we're asked about, are we able to breastfeed the baby when it's born? Obviously we will try and encourage that at all stages, but we have to be realistic. There are some consequences to the fact that they have a univentricular heart. Now, firstly, sometimes the baby is not in a position that we allow feeding straight away because there's reduced blood supply to the gut. So we need to check that baby is in a good condition to receive that. And secondly, baby is sometimes not able to actually suckle on the breast due to perhaps the medicines that they're on, or like the Prostin, for example. But what we would encourage if mum's wanting to breastfeed is that she expresses her breast milk, and then with the support of the nurses on the wards, that we could administer that when the baby's well enough and put into a tube, a nasogastric tube. When I speak about feeding, there's obviously several issues to consider as well, because you have to stabilise the baby perhaps before treatment and then afterwards as well. And invariably these children will have been on an intensive care unit for 7, 10 or 2 weeks perhaps, and therefore they've not been able to establish any form of feeding effectively. So sometimes these babies with a univentricular heart are working on less energy because they've obviously only got one side of the heart working compared to a baby who has got both. And sometimes children have great difficulties feeding by bottle or by breast. Some feed very well, but they struggle to gain weight. So therefore we have to maybe get them involved with dietitians for supplements and higher calorie feeds. And some babies suffer a lot from vomiting, and they become very breathless during feeds as well. So we sometimes have to instigate what we call tube feeding, which is a tube through the baby's nose and into their stomach. and sometimes parents actually have to learn how to do this on the ward before going home into their own homes. Alternatively, there's another way to do tube feeding, which is through a little tube through the wall of the tummy, and that's called a gastrostomy. So it's just to say that there can be very differences between each baby, and there's no way to predict how one will feed compared to another one. Feeding generally improves when baby gets a bit bigger, as many newborn children sometimes struggle with feeding, and usually when the child is coming up to the second stage or becoming onto solids, that the feeding sometimes can settle down and life becomes easier for everybody. A common question I'm asked obviously is if the parents would like to stay with their baby, which is completely understandable. Most centres offer parental accommodation, and that would be for mums and dads, and then if they had siblings, hopefully they may be able to stay as well. It's not something that we can promise, but we certainly would try to supply that. But obviously the fact that you've just had a baby, that will probably end up in a high dependency area or the intensive care unit, you would have a priority to accommodation. Sometimes fathers ask me, who should I be with? My wife, who's just had the baby, but unfortunately is not able to be at the hospital, at the children's hospital. This is an extremely difficult time for fathers, but we, the team here at the hospitals, would understand that. So I think his priority would have to be negotiated really, and obviously depending on the condition of his or her son or daughter, and also his condition of his wife, he will be able to visit the hospital whenever he can, because there's open visiting, and also if it makes life easier we can still offer him accommodation also. It's very difficult when a mum is separated from her baby after delivery, so what we would encourage dads to come and visit the baby, take photographs, gather as much information as they can, and then take it back to his wife or partner. Also, if I've met the family antenatally and I realise that there's a separation, it's something that I would do is make a phone call, or if not, ensure that the father has the direct number to the high dependency area where mum can contact the nurse looking after her baby. Once I've met the family on an antenatal visit, from that point onwards I will be available to them. So if there's any questions or queries or worries that the family would like to ask and they're not quite sure who to ring, they can always ring the liaison team, and we can, if we don't know the answer, we can certainly signpost them, because it could be an obstetrician query, it could be the cardiologist that I might need to find out some information for on their behalf. So we would always become a point of contact at that stage. When we're preparing a family for discharge, we often contact other centres. Some children actually get transferred to other hospitals, their local hospital, to be cared for, because it just could be a feeding issue, which is why we were able to transfer them. But often children with a univentricular heart will be linked up with a paediatrician at their local area. So there will be a number of people that families can contact. The family should be able to contact obviously ourselves, the liaison team, the cardiologist, a paediatrician and the GP. And also for support we always link up at health visitors, and if there's tube feeding or any extra medical need in the community, we would liaise with the community paediatric nurses. Once the first stage operation has been done and baby's done well and is ready to go home, parents often get very anxious about how to look after the baby. It is important that we do remember obviously that it is a baby and it will need all the usual baby care, but it is a huge commitment to look after these children, and they do need medication and extra vigilant observing than perhaps a child without this heart condition. I think parents' input into feeding when they go home is not to be underestimated at all. And although some children will do very well with feeding and reach their goals and targets, that that would be great. Other families really struggle, and the commitment to keep encouraging the feeding, because it might be tube feeding, it might be plenty of sleepless nights. Parents sometimes never get out socially. They can't, or they're anxious to trust somebody to babysit their child. So there is a huge impact on the parents, working parents in particular, and then siblings as well. So it's just not to underestimate the care that some of these children will need. Most parents ask me, will my child be able to attend normal school? And the answer would be yes. Most children with this condition would attend normal school. Some children will need some extra help attending normal school, but that would be managed again within the normal state environment. We encourage children to participate in sports at school, but many children will not be able to participate in the competitive element due to the limitations of their heart condition.